Okay, guys, I'm back with you now. We have 18 people on. Welcome to everyone. I'm Dr. Judith Leiber, former Director of Child and Adolescent Mental Health, Ministry of Health and Wellness. I hope that most of you were able to catch the gist of that vignette, that short video. Um, if you want to give me any feedback, what was the main problem?
Like the child wasn't at the developmental level that they should be, and they're not that verbal. Like they can say they want, but they don't really say much other words, and they didn't really seem to interact with their peers or their siblings.
Right. And what about playing with toys?
Fixation on one particular toy.
Right. And what kind of things did the practitioner try to rule out? Well, what was one of the questions that she asked?
They ever went unconscious.
Right. So she looking for possible epilepsy or seizures, right? And then she suggested an assessment, in-depth assessment. What type of assessment do you think that would be?
One for autism, maybe?
I'm sorry?
One for autism?
Yes, but even before that, just probably a more in-depth developmental assessment, you know, motor skills. You have developmental pediatrician, so they do motor skills, social, cognitive, and then play and they tend and language, sorry. Play and social skills be one. There's language, there's motor, and then there is cognitive. So they have a battery of tests that they go through, and then after that, then you would go into to probably doing a formal test for autism. And what was she suggesting to the mother as just a simple behavioral advice?
Good afternoon. That she should reward her whenever she displays good behavior. She should just clap since she enjoys the clapping.
Right. And she also advised the mother something about herself, meaning mother herself, how mother should take care of herself. You remember that?
So she asked her about her support system, like family members that can help her.
Right. Okay. All right. Okay, so thanks. I mean, yeah, you did well. You got the gist of it. And this is kind of typical, and I must say, um, autism spectrum disorder. Well, we've seen children presenting with more and more of these symptoms, right? Especially post-COVID. I mean, COVID was a 2020, but still, the effects still may still persist. And we are not 100% sure whether it's because of COVID, because they weren't socialized, because they were put in front of screens, um, or is it that, there is an inherent problem, in this particular child. So, for the most part, we until we can get like a formal testing if necessary, we give them recommendations regarding socialization with the child and decrease screen time because we know a lot of these kids are growing up on their tablets, um, and we reassess them until they can get testing. So they may respond spontaneously, see an improvement in terms of socialization and also their speech. If they're not responding as we would like, then we're gonna pass them on for more intense testing. Okay. All right, I'm gonna show you another one and then we kind of go into the meat of the matter, so to speak. Okay, guys, we're back, right?
We're here, Doc.
Okay. Right. So let's talk about the video that you just saw. What were the main complaints from this mom? Anybody?
Hyperactivity.
Yeah, and what else?
The seeming inability to focus on task or focus for any period of time on task. Yeah.
Right, yeah. Inattention, right. And you can notice from the little boy's behavior, um, he was kind of wandering around the examination room. I mean, they'll trouble you things on your examination table. Some of them will come and sit on your lap. It's the first time they're meeting you. So, all of that is in the mix. Um, oh, I wanted to ask you something about the previous video. Where did the lady say she had sought help before coming to the doctor? If you can remember from the previous video.
I think she sought help from some, I think it's like a herbalist or one of those,
Right.
right, naturalistic doctors, one of those.
She called it a traditional well, they translated it as a traditional healer. And I mean, that is an object lesson for all of us, that a lot, especially in the psychiatric realm, where things are not so obvious. The idea of something spiritual, something demonic, that maybe somebody obeah a picnic, always comes into play. So you always want to just ask about that, and I mean, deal with it sympathetically in terms of the culture, because we know what the culture is in Jamaica. I mean, unfortunately, we know also that, in Jamaica as well, I mean, people have thought that demons were in these children and they have beaten them. Unfortunately, a few times it has ended in death. So, we really want to be mindful of this. All right, so let's come back to the last one now. So, as I said, the little boy was kind of wandering around the room, and the practitioner was trying to explain. One, she explained that it's a condition, and I guess, do you mostly know the name of this condition? All right, if anybody knows it, can they say it?
Is it attention deficit hyperactive disorder?
Right. Yes. Thank you. Yes, and the mom. What was the mom's response to the fact that there was a diagnosis?
I think she was relieved, Dr. Libo, to know that there
Yes,
was a name that you could attach to this set of behaviors.
right. Yes, yes. And we find that often because they just think that, this is a bad picnic or something. But if you can give them a name, then, they feel somewhat justified that, yes, something is wrong. It is something that has been recognized. It's something that can be treated. Um, and the interventions, some of them were very similar to the ones before in terms of praise or, positive reinforcement as opposed to punishing. And the other aspect was the self-care. Remember, she was asking about, who could help her with the son. And if somebody could tell me what were the specific ones that would apply to somebody who had like an attention or um, problem maintaining focus. If you can just give me one recommendation.
So she suggested that they break up the task into sections.
Right, right. and yes, and you try to give them praise or something, in between, so that they'll be motivated to go on to the next section, or you cue them. So like in a class, you'd have the teacher saying, Johnny, have you done question one? And then say, okay, question two, Johnny. Question three, where the rest of the classes will probably go from one, two, three quite on their own, but she knows she has to cue Johnny to make him, keep up the flow. Right, right. So, and then she spoke about maybe referring to a specialist if necessary. And as I told you before, these videos are available in the what we call mental health gap intervention guide modules. The mental health team actually is trying to is in the process of rolling out these videos to primary care clinicians throughout the island so that they can recognize the different disorders and do primary intervention or just give primary advice. What I need to say about both ADHD and the possible autistic disorder is that in today's world, where our children are kind of glued to screens, that one and two, their attention span is not being exercise, so to speak. Everything must be a 2 minute or a 3 minute video. So sometimes it is hard if the problem is mainly inattention. Sometimes it's hard to differentiate. Is this really a disorder, or is it just something that has been created by our prevailing social circumstance where we put the kids in front of a screen and there are these exciting flashing images or videos that they've become kind of addicted to. So again, sometimes if you think that may be the problem, I mean, there are definite tests for ADD, ADHD. Advice is sometimes very similar. Cut down on the screen time and see if that really makes a big difference. Just to tell you as well, since I'm there, so this young fella would have attention deficit hyperactivity disorder because he is hyperactive, kind of moving about, but sometimes you only have ADD, attention deficit disorder, where it's just a problem with inattention and not much hyperactivity. Now, this disorder tends to be more frequent in girls. So unfortunately, it's missed quite a lot. The girls are just kind of in la la land. And I mean, they don't bother anybody. They may not be optimally doing their schoolwork, but they're still, functioning, passing. So it may not become obvious until maybe they go into higher grades where more is required of them. And, one gets the feeling that this person has more potential than they are actually showing. And then you may realize they have a problem with inattention. So I just want you to keep that in mind that you may have a difference in terms of presentation regarding boys and girls. All right, so I'm gonna go to my substantial presentation now. Any questions before I go? Where is my presentation? Oh, da, 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 da. Well, would you know it? My presentation is not here. Da, 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 da. Let me see, share. Oh, 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 oh. No, it's not here. Why is it not here? Okay, no, it's this one. Okay. Are you seeing way forward, guys? Hi, guys.
Yes,
No,
Doc, we're
no, we're
here.
only seeing your information on your drive.
Mm-hmm.
Let's try again. Share. Okay. Share. All right, you seeing way forward, guys?
Yeah, we're seeing it now, Doc.
Okay. All right, great. All right, so let me go from the beginning. Okay. Okay, so we're gonna take us kind of closer home to Jamaica, right? Mental health of children and adolescents in Jamaica. So I always say that whenever I should put this in, well, in, is it this slideshow? Right. Okay, so it's in slideshow mode, right? Guys?
Yes, it looks that way, Doc.
Okay, great. All right. So whenever I'm giving a talk about mental health, child and adolescent mental health, I always present a brain. Why do I do this? Because mental health psychiatry, has been kind of delegated to the to the what? Ephemeral sphere. It was thought that, well, it couldn't be related to science. It couldn't be related to actual, cells on the brain or actual functioning or an actual organ. But more and more, thank God for CT scan, MRI, PET scan, SPECT, all kind of these different fancy scans, we are now able to kind of differentiate, um, you know, associate disorders, let's say schizophrenia, with dysfunction in one particular area of the brain, and it gives us more ammunition to say, look, these things are brain disorders, right? And therefore, it closes the gap between mental disorders and physical disorders, which is what we are trying to do, um, in an effort to really reduce stigma and an effort for persons to seek help for mental disorders or to view them in a way similar to how they view physical disorders. For our adolescents, just to tell you, this little amygdala right here is what gives trouble or what becomes hyperactive in our adolescence. And this is the seat of anger, the seat of emotions, really. So anger, sexual feelings, aggressiveness, all of this um, resides here. And unfortunately, it's hyperactive in adolescent. Don't ask me why, right? I always say that when I go to heaven, that's what I'm going to ask God, because it's like He was almost setting up our adolescents for trouble, because this prefrontal cortex here, which is the um, purplish lavender area, is like the executive of your brain. So it allows you to delay gratification, to strategize, to make plans, just like what you'd expect a CEO, to inhibit impulses which may be detrimental to you at the time. And unfortunately, the prefrontal cortex does not get fully developed until about age 24. So you can imagine a poor adolescent, the amygdala, with all the emotions and drives and impulses, um, going at 100 miles per hour, and very little in terms of maybe prefrontal cortex to kind of inhibit all of these emotions, impulses, drives that are coming at the adolescent. And so we always say that, for us who work in the health sector and are interested in the health of adolescents, we need to almost be their prefrontal cortex, or to give them a framework where they can, there is some recognition that there has to be inhibition to these of these impulses. Okay. Now, this is something about emotional intelligence. And the reason I put this up is that years ago, when Dr. Earl Wright was the director of mental health, we did a public education campaign regarding emotional intelligence. The reason being that when people hear about mental, they go berserk and they think about mental disorders. And also, if you're in the pediatric realm, right, you have a kind of roadmap to say, okay, in terms of, let's say, walking, or the kid should be creeping first, then they start to hold on and take a few steps, and then they start to let go. So you kind of have a roadmap of how this child should develop in terms of their motor skills. In terms of language, we have a roadmap for that as well. You start off with dada, and then you graduate to maybe 2 words and 3 words, right? But in terms of mental or emotional development, we really don't have a roadmap for that, right? So a way of looking at it is really to do it from the emotional intelligence, emotional management point of view. So what we were trying to do, we still are trying to do it, is try to encourage parents to start giving the children words for naming their emotions, um, start giving them words for their emotions so that they can better manage them. Start showing an example of how different emotions are managed. So we're talking about naming, identifying emotions, naming emotions, managing emotions, right? So you can't expect to go ballistic over some, simple issue and then expect your daughter or child to be very controlled, when something angers him or her, right? So we wanted this progression in terms of identifying emotions, naming emotions, managing emotions, and this would have to be kind of taught from parent or whoever are the adults in the home to the child. And then the outgrowths would be empathy. You want to encourage your child to be able to feel what another child is feeling. So if a child has like a disability, um, you want to have that, to encourage that kind of self-reflection within your child. How would you feel if you had a disability and you had to, maybe limp and have a limp all the time? How would you feel if people laughed at you? So then the fourth thing would be empathy, being able to feel what other people are feeling, and also being able to interact well with other people. And you have some other outgrowths like being able to motivate yourself, being able to make, wise decisions. So this was our attempt at giving a kind of roadmap to emotional development, really, in our children. As I said, we have a roadmap for language development. We have a roadmap for cognitive development. We have a roadmap for how they should be physical development. So we're trying to give a roadmap in terms of trying to help our children to to navigate the world of emotions. We know that in a lot of settings, emotions, behavioral, mental is like not in again, and you call it either emotional health or behavioral health. So that is really giving way to, well, making concession to the fact that mental still carries a heavy amount of stigma, right? Anyway, a lot of brochures were produced and a manual was also produced. So that is available. And in modern lingo now, they talk about emotional modulation. That's the latest thing. helping children to modulate their emotions, which is the same kind of thing, managing your emotions, right? So it has different terms, but it's kind of basically the same thing. In the history of child and adolescent mental health services in Jamaica, there was maybe in the 1960s a child guidance clinic really in the S&P of university. But well, it was staffed by an expatriate, Dr. Feldman. So when he left, that clinic, folded, right? So in 1980, here comes Dr. Milburn. She is a pediatrician who went away and did child psych. And she started a clinic at the Comprehensive Health Center. And at that time, nobody knew what child mental health disorders were. Nobody knew what a child guidance clinic did or was, right? Um, and it kind of gained validity through its role in child abuse awareness. UNICEF invested in a project with the primary role of which was to really build child abuse awareness. I mean, now, many years on, people are aware of child abuse. They're aware of the different types of child abuse. We have reported mechanisms, but in those days, that none of that existed. So this was a way to really, UNICEF helped Dr. Milburn to really introduce the concept of the child guidance clinic through child abuse awareness. The other thing too was that on the grounds of the Comprehensive Health Center, there is a STD clinic, sexually transmitted disease clinic. So what would happen is that whenever a child came there who had, a suspicious discharge or any discharge, they had referred over to the child guidance clinic for a kind of interview just to make sure that there wasn't any foul play. I mean, some of the discharges were just innocuous, but there were some that, of course, were more sinister and would have needed much more investigation. The other thing about the original clinic, as I said, nobody quite knew what. Sorry, I'm sorry. Nobody quite knew what a Nobody quite knew what a child guidance clinic was. So, another stream of referrals came from the schools. There was a school health program. There was a school health program many years ago. A lot of you probably don't know it or even remember it. And then when administrations changed, it was dissolved, unfortunately. So there were a lot of school nurses who didn't have a job in the schools anymore. So Dr. Milburn got two of these school nurses to work with her, right? So there were two streams of clients coming in. The ones possible victims of child abuse, especially sexual abuse, and also the ones who were exhibiting behavioral or emotional problems at school. All right. And then from that, people became more aware of child adolescent mental health. It really was, in fact, a discipline within itself. All right, just to say that, in the early days, we really didn't have all these nice distinctions of child abuse. And I mean, daily they add to it, like they'll say, children exposed to violence, child trafficking. So daily they're adding to different types of child abuse, children in conflict with the law. And well, this is just a provocative question at the end, how far child perpetrators, victims themselves. That's a provocative question for you to consider. In fact, Dr. Milburn had tried to develop a system where she'd get reporting from the clinics island wide whenever they saw a case of suspected abuse. It wasn't mandated, there was no law, it was just her trying to do it, because of we're always told, oh, if you don't have figures, you can't make a case that there's a problem. However, the persons in the field, like the nurses and the doctors, they weren't mandated to do it, and they felt that reporting it would have put them at risk, from the possible perpetrators in their villages or in their communities. So that didn't really stick. So that's why mandatory reporting had to come in, so that you'd have this cover of legal direction, of a legal order to say that I have to report, right? And the framework for child abuse and it's the detection of child abuse and protection of these of children, has taken some time, but we have a good what I call menu of services. So the Child Care and Protection Act came in 2004. They're supposed to be revising it as we speak, but for some reason it's not quite out yet, right? And you have the Office of the Children's Advocate. Now, in the early days, the children's services used to be in charge of most of the children's homes. And of course, reports arose that the children were actually being abused in the homes. So obviously, the children's services could not investigate themselves because they were the ones who were managing these homes. So then they said we needed another office, the children's advocate, so that if any child was in a home and was being abused by some agent of the Children's Services Division, they would have an independent party or independent body to report to, right? And then the Office of the Child Registry is really supposed to be the gatekeeper. So all record of and it's suspected child abuse, right? You don't have to, they're not asking you to investigate, you just have to suspect it. Go through the child registry so we can get fairly accurate figures. We all know that child abuse is underreported, but we're getting better figures. And of course, the Children's Services Division, which then turned into the Child Development Agency, which is now the Child Protection and Family Services Agency, is the agency which kind of has control, responsibility for all the children in Jamaica. All right. So we have this framework which is pretty good. And of course I mean there are always pros and cons, right? For instance, let's say the mandatory reporting, you'll have, let's say, a 14-year-old who goes to a guidance counselor, and let's say they have like a sexually transmitted disease. Um, the guidance counselor is kind of mandated to report because a 14-year-old should not have sex, right? And we know that according to the law, and we know, I don't know if you've been following the news where they're now talking about the age difference between sexual partners, especially if they're minors, and when it should be criminalized and when it should not. So those are issues which we probably will never agree on. And then there's also the issue of what age should be the age of consent. All of those issues continue. And, ever so often the discussion arises because of some incident, and, everybody has their piece to say. But from our, point of view, we really want to, as children advocates, we really want to diminish criminalizing sexual behavior between children because we realize, as I say, the hormones are just raging, and the control is limited. A lot of people who argue from the other side, they say, oh, they want to criminalize, so to speak, because they want the children to be less vulnerable to, let's say, dons or older guys and I shouldn't say guys or girls, let's say, in the community. So it's an ongoing debate, and it kind of depends where you sit and I guess what scenarios you are aware of. Okay, so back to mental health now. Um, well, I mean, child abuse is a part of mental health, but let's back to mental health proper. Just to say for all of us, whenever we hear mental, we go to mental illness or mental disorder rather than talking about mental health. Our Minister of Health and Wellness, he has been very instrumental in terms of promoting mental health. And, he has recognized this kind of anomaly whereby, we just kind of cross out the health and put mental illness whenever we see mental. So he has advocated that we speak about mental well-being, mental well-being. So it takes the term out of a hospital setting where you're sick or you're not sick, and kind of has a more global implications, because well-being is a more holistic term. So that is the kind of current lingo to speak more of mental well-being. This is just, again, something for you to think about. Child mental health and psychological well-being are the responsibility of all in a civilized society, not just some. And looking at well-being, right? So we have, okay, so the talk was child and adolescent mental health disorders or whatever. But I'm taking out a step back, like how do we make sure our children are well, as opposed to how do we detect that there's a disorder? Because we want to make sure that they are well, so that we don't develop some of the disorders. So children need to know that they have material well-being, which means food to eat, maybe clothes to wear, and a roof over their heads. And you can imagine post Melissa, this feeling has probably been shattered in a few of our children. They want to feel healthy and safe. And again, this may be a challenge, let's say, in some of the inner city communities. There was an article in the Sunday paper, the title by a policeman, McCoy. He always writes about kind of social stroke police issues. The title was Fearing for Your Child's Development. And basically, he was referring to the fact that in some inner city gang-led communities, mothers or parents fear that their child become, go into puberty because they fear that now the Don is going to call for her so that he can, have sex with her, and then he or she, let's say, may be passed around the gang. So, safety is very important for the well-being of our children. We want educational well-being. I mean, whether you are developmentally challenged or not, I mean, every child needs to feel like they're on a kind of learning curve. They're learning something, even they're learning as slow as, and very, very slowly, or they're learning a skill. So we all need to, this is our thing that we need to stress. And also to say that a lot of the children who come to child guidance clinic, they may have behavioral disorders, but they also have learning disorders. Learning disorders is one of the biggest in terms of diagnosis there. So there definitely is a relation. If you're not learning, if you're not if what the teacher is saying at the front of the class means nothing to you, you're going to start distracting the people around you. You're going to start migrating so that you're kind of sitting at the door. And then after a while, you're going to stop coming to class, maybe be on the corridors, play or somewhere in the school playing marbles or gambling or something, and then you may end up at the bottom of the play field smoking ganja, right? So you can see that progression. So that is why we need to really know how our children are doing in terms of education and make sure that they have um, a set level of level of numeracy and literacy. Speaking back again to the Sunday newspaper, Miss Baston, who was the prime minister of sorry, the principal of Campion College, she has well, she retired, but she has actually started an academy. I think it's at Alpha, grade 7 academy for children who are really not numerate or literate. And there was an article of how they had made certain, progress. Some of them had skipped like 2 or 3 grade levels in terms of reading. A lot of these programs are software supported, so you have to buy a software, and the kids use the software to increase their literacy. So that is encouraging, but as you can imagine, and I know, and even, well, not even. There's a program called Citizen Security Plan, and in it, the Ministry of Education also has a software that they're using for the children who, are challenged in this area. Because, as I say, it becomes quite obvious is that, learning disorder and behavioral disorder kind of go hand in hand. Children want to belong to a family and also want to, have good relationships with their peers. And they want to feel within themselves that they are, feel good about themselves, all right? And simply stated, they want to be healthy, they want to be safe, they want to enjoy life to a certain extent and to feel that they're achieving. They want to feel that they're making a positive contribution to school. Actually, um, a sense of school belonging is a protective factor for children having like behavioral disorders, particularly those children who may be like in inner city situations. And economic well-being, I don't think they want to be rich. As I said, they just want to know that they can get the meal, they'll have a roof over their head, and they will have clothes on their backs. Okay. All right. So this is the biggie now for you in terms of Masters of Public Health. So if you think of a neurosurgeon, everybody kind of idolizes a neurosurgeon. Oh my God, he must be very bright and very skilled. And I mean, if you're going to have a neurosurgery procedure, you're talking the millions, right? But drugs and surgery may improve the health of individuals, right? So one individual, but its measures such as clean water, proper diet, and immunization that have improved the health of populations, right? So I think COVID brought that out very, very, very starkly. That the health of the population is very, very important. And things like immunization, hygiene, you can add whatever you want to all of these factors, are very, very important in terms of the overall health. And for us in the mental health field, we would say that the measures such as parenting, and you have people now who they have prefaced the word parenting with like positive parenting, gentle parenting, to emphasize, to de-emphasize the role of punishment, especially, physical, corporal punishment. And we know that has been an ongoing discussion in Jamaica. I'm not going to take that up. Child protection, again, we have made it everybody's responsibility. And for us in the health sector, if you don't report, you can be fined up to 500,000. Emotional intelligence, again, we want to make it again island-wide, population-wide uh, what status. We want to improve the emotional intelligence of our population generally, right? And certainly within the schools, they have been trying to promote all of these kind of family, what they call life skills, families' life skills in the HFLE, what they call the HFLE curriculum. I think a lot of you probably have heard about it. So it's another way of kind of raising the educational level of our children with regards to their health and regards to how they need to relate to others and regards to, family life. I told you long time ago there was a school health program, but it's no longer operative. What we have found in the child guidance clinic is that the children are usually referred from school, but sometimes they don't end up coming to the clinic because parents who may be, lower socioeconomic group, they may, if they come to clinic, they may be paid by the day, so they're going to lose the day. They have to get lunch money and bus fare for them and the child, and it's just too expensive. So they may come once or twice. So that is why we have a proposal to have like a um, mobile clinic so that we would see the children in school, with the permission of the parents, so that this percentage of kids who are falling between the cracks would lessen. When you talk to children, they always talk about confidentiality with the guidance counselors. And I know that the guidance counselor organizations have, over the years, tried to improve their image, as being confidential persons. But you can imagine it just takes one bad egg, for this whole thing to raise up again. So it's a constant struggle when you speak to the kids, or when you're speaking to them and you say, okay, ideally, how it should be is that the teacher recognizes something is happening with this child. The teacher speaks to the child and recognizes this is something I can't handle, or I don't know what's happening here. She refers it to the guidance counselor. The guidance counselor then should do a little bit more probing and should decide whether or not this is something that can be handled at her level. So let's say it's a child who is just not getting breakfast in the morning, or not, or having a meal every other day. It may be something that the guidance counselor can deal with. If it is not that simple, so to speak, then the guidance counselor would then refer the child to either child guidance clinic or somewhere else. But a lot of times when you speak to the children, that step of going to the guidance counselor is kind of tentative for them. It's not desirable because of the issue with confidentiality. Okay. This is to
And
this
that, Dr. Liba, sorry.
sorry.
I just wanted to add to that to say that is very true. And the issue, one of the underlying issues with that, influencing that, is that guidance counselors oftentimes, once they upgrade themselves in that area, they're promoted from within the school. So they're once teachers and then they're promoted to that position. But the students still see them as how they were prior to filling that role. They're the same person. And so
Yeah.
whatever issues existed before, or however their attitude was before, the students still perceive them in that way. And so it's that
Yes.
creates that barrier for them.
Yeah, that's true. Thank you. There's a great deal of stigma, yes. And as I said, the organization has really tried to
Now, gonna we
destigmatize.
must have you right because you're right that will prevent you from moving about. Happy New Year.
Sorry. Okay. Oh boy. Anyway,
Kashai, mute.
somebody's thing is open. Anyway, all right, let me press on. just from a general point of view, we all tend to want to like identify a problem, pathologize it, and then treat it, right? But there'll never be enough clinics or enough therapists, which is why I put up the slide about well-being, because the more of those factors that we can get right for our children, the less, behavioral or emotional disorders we will see. Talking about pathologize, for instance, like attention deficit hyperactivity disorder, I mean, a lot of persons outside of the child arena feel that ADHD is just an attempt of child psychiatrists to pathologize bad behavior. I'm telling you, they don't really accept it. They think that we're pathologizing bad behavior, right? So we even have to surmount this mountain of stigma within our own health sector, right? So it's an uphill battle on all fronts. Okay, so again, I'm stressing again health promotion and how we can kind of build the scaffold, the right framework, so that the amount and number of the number of mental disorders lessens, right? So you start with health promotion from prenatal. We've tried to introduce antenatal depression screening. I think it is underway in most places. But it definitely has been shown that antenatal depression can certainly affect the baby, and unfortunately, it affects the part of the neonate that controls behavior. So you can imagine a depressed mother with a child who is acting out, just double whammy, right? So we are trying to stress, the importance of the antenatal period to the emotional development of the child. Then there's infancy, where the bonding takes place. And in the ministry, well, there is a program called Reach Up, which was developed many years ago by TMRU folks, Susan Walker et al. And what it does is that it developed a very culturally sensitive, simple kind of one-on-one child stimulation program for at-risk mothers. So ideally, you have a mother who's coming, she's a teenager, she don't have much support. They should be identified in the clinic when the baby is born. Then you would get the community health aides who you have taught in this methodology to go and visit this mother on a regular basis, show them how to play with the child, to show them how to make like these mobiles that you hang from cribs to stimulate the child, to make it out of simple materials around the home, to teach the mothers how to interact well with their child. And it has been shown that it makes a big, 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 big difference. Although it was developed in Jamaica, it has only become really institutionalized. It was pre-COVID actually that it started. And of course, with COVID, it kind of put some spokes in the wheel. But what they did was that they tried to still keep in touch with the parents by telephone. And right now, it should be at a point where, it should be happening in more and more health districts. As I say, you kind of depend on the community health aides to go out, and they would be supervised by, let's say, the public health nurses in the clinic. Okay, preschool. I don't know how many remember this great emphasis on early childhood education, how important it is, etc., etc. So the ECC was born out of that. And in terms of mental health, we had an input in terms of the training curriculum for early childhood practitioners, which usually comes out of heart NTA, right? So there's that component in terms of emotional intelligence. Then, your school age, and we're talking about one, the health and family life curriculum, and we also recently introduced school mental health literacy curriculum. So we're really hoping to increase the mental health literacy of our children, to decrease stigma, to also increase the knowledge in our teachers so that we're more open to speaking about mental health, to the encouragement of mental health, and to seeking help when necessary. All right. All right, some statistics, 10 to 15% will have a mental disorder during childhood and adolescent. And what I don't have here is that 50 to 70% of all disorders will actually start around age 14, right? But what happens is that they do not come to, they are not properly diagnosed until about 10 years after. So you can imagine between the ages of 14 and 24 are like vital years for a kid. They're doing their CXC, they're doing their, what's the other thing called now? CAPE. And then they're deciding, what kind of training they're going to have after CAPE or after sixth form. And then they're looking for a partner. They're making friendships that they hope to last a lifetime. So that is why we are stressing CAMH, because if we can catch them at age 14, 15, 16, and do some kind of intervention there, then the whole trajectory of their life will be different. Okay. Just to mention that a lot of the problems that we see, particularly in the youngsters, is not really coming from an internal pathology, but really because of environmental circumstances, poverty, violence, abuse in some form or fashion, substance abuse, really external things. So that is why, clinic work per se is not enough. We have to raise the level of social conditions generally in our island, and particularly in our most vulnerable communities. These are just some figures of the client visits, a little bit dated, forgive me. But what I wanted to show you is that we have a good spread of clinics throughout the island. However, only about 3 of these clinics are really open 5 days a week. The rest of them are on a kind of, variable schedule, maybe once a month, twice a month, 3 times a month, right? So that is the challenge. Most of them can be accessed through the adult mental health clinic. So the adult mental health team actually visits the clinic about 100 or 110 clinics throughout the island. The island has about 300 plus clinics. So the adult mental health team has a really good penetration. So, wherever you are, if you go to the adult clinic and there's a child who needs a problem, the adult clinic can then refer you to the child guidance clinic. Sometimes it's the same staff who see both, who see the adults and the children, which is not ideal, but that's just the way it is. And sometimes a clinic arises because let's say suppose you're in Black River and you go to clinic with the mental health clinic every week, but you find that a lot of teenagers are coming to the clinic. You don't want to have your teenagers and your adults in the same space and time. So you may say, okay, on the fourth Thursday, I will see teenagers alone. So that's how a lot of these clinics evolved, right? So it's a ongoing battle to try to get more staff and to try to get staff which are dedicated to children alone so that the children can be seen. And then, as I told you, that what we have in the wings is a mobile clinic. So we're hoping that, especially post Melissa, we'll be able to visit some of these places where the physical structure may not be at, may have been decimated, and the expertise may not be in the Western area. We can transfer some of the skills to the Western area. Right. This number, it's about 25, right? And it's not clinics, it's actually clinic sites, as I can tell you. A lot of apart from the 3 clinics that I told you are open every day, we share spaces. It's not ideal because in a clinic setting, you want a kind of ambience so that the child feels relaxed to share about, delicate and very intimate matters. So that can be a challenge. And we have, as I say, limited amount who see children only. We have a range of professionals who work in the clinic. Right? And apart from
Sorry,
these professions, sorry,
Dr. Lebo, my apologies. Can I see that slide that came before with the breakdown of the available services?
where?
Right after the map.
This?
No, before
This?
this one. It
You mean,
had the numbers, the 30, the 20 clinic, child guidance
oh,
clinic sites,
oh,
yes,
yeah.
there's 13 professionals, children only.
This is a bit dated, but it's not, there's not been much. It may be,
Much change.
yeah, not much change, yeah.
Okay, all right, thanks, Doc.
Mhm. Yeah, so right. Apart from, these kind of well, I wouldn't say standard because the idea of psychologists and social workers is almost like a fairly new concept to health. I don't think our health persons have really recognized, or I hope they're in the process of recognizing the importance of these persons to to our society in general and especially to our children. So apart from these though, you have like therapists, people who have developed skills in, certain types of therapy, where they can work with children. We know that a lot of, well, younger children, they are nonverbal. They're not going to come in front of you and say, "Oh, I'm hearing voices, I'm sad." No, no, no. They're not coming with that, right? They're just kind of acting out. So you have these different modalities, sometimes art therapy. You get them to draw, and by so doing, you can get an idea of kind of what's going on in their inner sanctum. You enlist them in play. There are different types of play therapy, sand therapy. You may have like a dolly house with with different figures, and you just allow them to configure the setting the way that they know how, and from that, you can get an idea of what's going on. Sometimes drama therapy. I know, like Elizabeth Ward, she felt not she felt it definitely can help, like drumming, things like that. And like Prof. Hicklin, he developed something called Dreamer World, which had a lot to do with arts, drama, drumming, music, um, as a way of reaching the children who may have behavioral or emotional problems. So there are other ways of reaching children, particularly those who are nonverbal. We're not going to sit down and tell you their problems, right? Um, or so even older children. I mean, they're not gonna just sit down most of the time and just like, "Oh, doctor, I have," like what you're going to say, "I have a cold, I have a running nose." No, they're not going to tell you that. But somebody has noticed that maybe they're not doing well in school, or, they have tantrums, or they get angry for nothing. So this is a way of kind of, as I said, tapping into their inner sanctum to kind of see what's happening and see how you can help them. Mm. Okay. A big challenge in terms of CAMH is the perception of the general public. As I said, we are trying to carve away the great mountain of stigma which um, which currently obtains. I must say that COVID, I mean, it has its bad, but it had some good as well. The helpline was started actually before COVID. It was in response to what we perceived to be a fairly high level of suicidal ideation, particularly in our youth, right? Some cited up to 30%, 20%, right? And it came in very, very, very useful in COVID because you couldn't go to face and people could phone in, right? And out of COVID, we've actually developed two more two more helplines. So you have the mental health and suicide prevention helpline coming directly from the Ministry of Health and Wellness. We also twinned with UNICEF to develop something called You Matter, and that arose out of they have a social messaging platform called You Report, and again, when they did surveys on You Report, the mental health surveys just kind of lit up. I mean, they had the most participants there, people talking about suicidal ideation. So the UNICEF, I mean, there is this program called You Report, where they deal mainly with text messages. The rationale is that sometimes a lot of our teenagers don't like to speak on the phone, but they will text. That's one. And two, you can text, you can text in the middle of a class. No, for argument's sake, I'm not saying that. But basically all I'm saying, you can text in a more secretive fashion than having to actually speak to somebody. So that You Matter was developed where it's texting, and then again, the advantage of that is that yes, you pick up emergencies, but you do have a certain amount of time to think about the answer. When somebody has sent you a query, the You Matter actually has a kind of inbuilt mechanism where they have like a what we call customer service thing after the call, where you're asked to read, well, where most of your queries are, where most of your questions answered. So there's a kind of inbuilt mechanism to assess, the effectiveness of the service. And just to tell you generally that helplines tend to be very, very expensive. If you can get volunteers, that's fine. For the You Matter, there's a constant stream from the master's students in psychology. So that has been able to survive because, it's mainly volunteer work. So it's a kind of win-win situation. We get their service. We employ a psychologist to oversee them and to do their training, and they get their practicum hours, for their psychological qualification, right? But for the mental health and suicide prevention helpline in the ministry, we generally, it's paid. We have to pay the persons who come on, so it's much more expensive. The children's advocate started a helpline, stay safe spot, right? And I think it's mainly volunteer, and it's really for 0 to 18. So she can accommodate, a 2-year-old, sorry, just for argument's sake, 2, 3, 4-year-old calling, that's fine. With the other helplines, we have to be careful because we're told that for us to treat a child below 16, we should get permission. Of course, you can't take that too strictly, because if a child, 14-year-old, calls and says they want to kill themselves, you're gonna try to talk them, de-escalate the problem, and then you get some help for them. But as I said, the advantage of the Safe Spot helpline is that because the children's advocate is basically like the big lawyer for all children, then she can present the line as being open to all children. You can call and talk, no problem. All right. All right. So I would say this perception, I think the helplines have been helplines, our PR campaign, and especially Mrs. Williams Ray. Now we worked on a campaign, Do Your Share. Um, and Minister was involved in that as well. So campaigns like that, I think they're carving away at this mountain of stigma, right? But it's an uphill battle, right? Another thing about perception is that men don't usually seek help, right? Even for physical problems. But on the helplines, they may call because it's anonymous. And in fact, if you look at the figures, it's like 2 to 1. So for every 2 women that call is one man, but at least they're calling and getting some amount of help on these lines. So to me, that's another big advantage of the helplines. Okay, expectation of the clients. What I call the mechanic shop syndrome, where your car not working right, you take it to the mechanic shop, you leave it there, and he says, okay, I need to get this part, that part, come back 2 days time. This is the cost, and you come back and it's running well. And a lot of our clients, usually our parents, they think that that's the way that it works. Mental health treatment works. And they don't realize that they have a big part in it because, you're giving them recommendations and trying to kind of, develop a roadmap for them in terms of this child's behavior and so forth. And a lot of it has to do with them. A lot of times we go to school with the parents' permission to talk to the teachers in terms of, let's say, a child who has ADHD, what's the best way to manage that child in the classroom, right? So they have expectations that this child will just suddenly become well or well behaving like that. And sometimes they don't really apprehend how much, they will have to be involved as kind of co-therapists, right? And they kind of see it, like let's say you have a toothache or an earache, and you go to the doctor and you get antibiotics and you feel better after a while. So the difference between, the modalities of treatment and the effects and the expectations is something that you have to explore and to make them very clear about, or else, they're gonna lose faith in the process because they're gonna, compare it to their regular physical health visits, right? And now and again, we have done client satisfaction surveys to see how our patients are thinking. Okay, so we have some gaps, but right now, I mean, a lot of CAMH is outpatient, meaning that they go to the clinic. We really keep inpatient to a minimum, but there are a few times you really have to admit them to hospital. Sometimes it's the suicidal patients they admitted at Bustamante or university, and I know even in the general hospitals out in the country. University has a day hospital, which is where you would have the person come in the daytime, but they go back home at night. We don't have that anywhere else. You may have specialized clinics. I know Dr. Pottinger used to have a grief and trauma clinic. I'm not sure if it's still operating. Many years ago, we tried to introduce what is called therapeutic foster care. And the rationale for this is that, you have certain children who have been so emotionally damaged that a regular person doesn't know how to deal with them, you know, and therefore they have to be taught certain skills. So we were given the opportunity to get some training for some of our children officers. It was in Cleveland in therapeutic foster care. But unfortunately, we haven't really been able to actualize it much in Jamaica, right? Then they have the residential treatment center. Now, a lot of people would like this because like it's a way of kind of getting rid of the kids, right? Um, but we don't, well, the government doesn't provide a residential treatment center. And no, when I say the government, Maxfield Park has a center for children who require more intensive psychological and or psychiatric work. But that is really for, the wards of the state. Um, uh, John Blow off the street can take a child, his child who is misbehaving, and say, look, I want him admitted to this center, because he's misbehaving, right? So we really discourage inpatient or residential treatment, and we favor more outpatient treatment. Um, and as I said, we may have inpatient treatment for a period of time. You have some difficult cases. I know Dr. Lowe up at university there, she has admitted people up to a month, 2 months to really get to the crunch of what is happening with this kid. A lot of children have they don't have one disorder. So you may have anxiety plus depression. So it's a, it may take you some time to kind of disaggregate everything that's going on with this child so that you can help the child. I mentioned the different types of therapy: psychotherapy, art, drama, music, pharmacotherapy. Just to say that a lot of people, they are squeamish. They cringe at the idea of maybe giving a 7, 8, 9-year-old medication for like depression or ADD. Again, this is an uphill battle of trying to convince parents that the children are not going to be addicted to this medication. We tell them about the side effects, and we're there to assist them. And day by day, the medications are becoming. You have a greater variety, and you can, some people just react better to some medication, right? So our armamentarium is much wider. But as I say, you really have to kind of go through a kind of educational module with the parents to convince them that the education that medication is in order. And sometimes you have to talk to the auntie or the grandmother at home, because the parents may agree in the clinic, but then when they go home, the grandmother or the auntie, who is like the power broker in the family, says, no, 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 this child not getting no medication. And that's the end of that, right? So again, that's another thing you have to fight. In terms of medication,
Dr. Lebo, I have a question about the pharmacotherapy.
yes, ma'am.
So I wouldn't say I'm personally averse to this as one therapy modality, but because of what you explained about the brain, isn't that potentially problematic in terms of the adolescent is under the adolescent brain is under development, and you did say that there is no specific roadmap around how mental health development takes place. And therefore, I suppose maybe intuitively it feels like if you introduce medication into that mix, it potentially could become problematic. What is your sort of personal view on that? How do you navigate that kind of balance? The adolescent brain under development, no real roadmap for mental health development, and then the pharmacotherapy piece that is being thrown in.
Okay, well, what I would say is that the medication we have are specific, right? So they're either like to treat depression, maybe to treat ADHD, to treat anxiety, right? Um, and because this person is showing symptoms, okay, let's say depression. If the depression is mild, psychotherapy along with, let's say, exercise and other non-pharmacological stuff will work. But once it goes to moderate or severe, you need to introduce some medication. Now, my analogy is this. It's like making a cake. Um, that how does one put it? If you have the right ingredients in the right amount, the cake comes out good. If you don't, the cake is a disaster. So what's happening in some of these kids when they have depression or anxiety is that there is some imbalance, and I think you've heard of all this chemical imbalance theory, right? Some people poo-poo it, but it the central tenet holds that there is some kind of imbalance in the neurotransmitters, like the chemistry of the brain, which is causing symptoms. And therefore, you want to introduce something that's going to kind of rebalance the environment. Okay. It they don't affect development. They affect like receptors on different areas, so that we try to in an effort to bring the balance as close as normal, as close to normal as you can.
Okay. All right.
Right. Right. As I say, it's I can understand and a lot of parents think, oh, they're gonna get addicted to it, which they don't. Um, right. For instance, let's say ADD, they will say, oh, they're gonna get addicted to it, right? But what we show them is that if you don't give them the ADD meds and they continue with the hyperactivity, impulsivity, they are more at risk of actually, try experimenting with substances because of their impulsivity. And therefore, they may end up addicted to a substance instead, So, our medication will actually prevent that eventuality. So, but as I say, I can recognize the inhibition and the hesitation. Um, okay, another thing about pharmacotherapy, I mean, maybe I'm shooting myself in the foot, but some of the medication, like let's say studies were done on adults, right? And because of, I guess, FDA guidelines or whatever, they can't do it on teenagers. So sometimes you have to take a leap and do what we call off-label, right? This thing works in an adult, so therefore I'm going to try it in you because no other medication that I have has been working. So as I say, it's not a clear feel, it's not cut and dry, but it work well. Most of them work. All right. Um, I mentioned about NHF, and so I think most of you know about NHF, right? If you go to like a drug serve or the NHF pharmacy, you can get whatever medication is on the ven list free of cost. However, there is another NHF requirement, no, not requirement, service, whereby they will subsidize drugs at any pharmacy, right? So you may live out in Ulster Spring. If you have this condition on your NHF card that, yes, I am suffering from ADHD, if the pharmacy can procure the ADHD drug, they can buy it from your pharmacy and it will be subsidized. So that has been a barrier for a lot of parents for the ADHD drug, because they were very kind of slow to put Concerta on the what we call the individual benefits listing. But thankfully, this year they did put it on the listing. So it's much more convenient. The parents don't have to go to drug serve to wait the whole day to get the medication there. And it doesn't have to be written on a public prescription pad. And they can get it, wherever the pharmacist wherever they find a pharmacist who is willing to order drugs. So it has made it much more convenient for the parents. The physical plant, we have deficits in the infrastructure. I told you that most of them are shared spaces. So you may go to your clinic maybe, let's say, Thursday afternoon, and there was surgery clinic before your clinic, right? So you have all of the paraphernalia, from surgery clinic there, which you kind of have to get out of the way so that you can set up your clinic. And as I said, there's a thing about ambience and, getting your children in the mood to talk to you, and especially about, difficult, intimate, delicate subjects, right? And what we find is that sometimes even when we solicit and get, let's say, a trailer for ourselves, right? So you may beg, let's say, a Rotary for a trailer. This happened in St. Anne's, and you fix it up the way you want it. Lovely couch, lovely pictures on the table, wonderful. When the latest emergency arises and they want an isolation area, well, guess where they take over? They take over your little trailer, which is by itself. You understand? So these are the kind of vagaries to which child guidance clinics are exposed to in terms of the health sector. But we press on, we press on. Okay, I'm just gonna show you two more slides. I'm mindful of the time. Give you an idea of how at what ages psychiatric disorders develop. So this is an old term for ADHD. So around 5 to 7 is when ADHD will be developing, right? And anxiety disorders may also develop at this time. It may not be flagrant. So we have something called separation anxiety disorder. So this may be a child who cries a bit longer than the other kids when they first go to kindergarten or wherever, right? But after a while, it becomes more and more obvious. They may develop social anxiety, generalized anxiety as they get older. So you may see the beginnings of these at around age 5. Now, at around age 12, around puberty, and unfortunately, our girls are going into puberty earlier. So it may come to 10, right? You have depression arising, and it goes up exponentially in girls. We're not sure why. Okay, so you'll have, let's say you measure depression in boys and girls from age 5 to 10, about the same level. But as soon as they hit puberty, the level in the girls will just shoot up. We're not sure why. Some people say, oh, it's because the boys don't complain, right? And that what the boys do is that they go and use substances, because substance use disorder shows its ugly head around that time in the boys. Okay. So this is what you're kind of looking at, when puberty, after puberty. So you have to be mindful of this. Depression screening is indicated in some school medicals because we're aware of this problem. All right. And of course, I think most of you know about NCD, National Council of Drug Abuse. They have a helpline. I think it's 9 to 5 though, but they've recently really kind of restructured and they've got more posts. So I think they can offer much more services to persons who are seeking help. Okay, so Right, sorry. So this is your mood disorder, which is your depression, or your bipolar. Bipolar not so common, but it's more depression that's gonna be common, and then your substance abuse disorder. And schizophrenia may emerge here, but again, it's probably undetected. The person might be hearing voices, the youngster. He's not sure what's happening. He knows that nobody else hears voices. He's not going to tell anybody. He tries to mask it. Maybe if he smoke a little ganja, they go away or he feels better. So sometimes they start using substances because of this. And it's only when they might get like a season spliff and they go really psychotic and start climbing the walls that they get admitted. And then when you dig into it, you realize that they were hearing voices all along. They didn't tell anybody. They tried to self-medicate and then it kind of blew up. Just to say anxiety disorders, some guys have like social anxiety disorder, which means that like excess, I mean, they're very, very anxious in social situations. What may happen is that they go to a party, somebody give them some alcohol, and they find that, oh, wow, inhibitions are loosened. They can talk to the girl they like. They have a good time. All goes well. So what gets riveted in the mind is if I drink some alcohol, I will be just like everybody else. I can socialize. I can get the girl that I want. And sometimes that's the genesis of, alcohol use disorder. So these are all the kind of pitfalls that our youngsters, may get into. One last slide. Well, one of the last slides. No, this slide shows you morbidity throughout the ages. 3 more minutes to go. And mental disorders is in this kind of peachy color, right? Musculoskeletal is like this color, and cancer is the blue. And if you look coming from age 0 to 10, chronic respiratory is bigger than mental. Fine, you have asthma, whatever, bronchiolitis, right? But at 10, you can see where the peach rises. Mental disorders, both in men and women. And from about 10 to about 40-ish, it is taking the lion's share of the morbidity, right? After about 50, a lot of the mental disorders, they kind of peter out and you get like cancer or neurological, like your dementia and so forth. But this is to underscore the fact that there's a great deal of morbidity between age 10 to 40, which is this is your working age people mainly. This is when you want to train your workforce so that they can come and be productive when we retire, right? So a lot is happening in this age, and a lot of mental disorders are emerging, which is why we say it's important to look at this age group and to intervene as much as we can. Okay. All right, I think I'll end there. Thank you for your attention. I'll take any questions now.
Dr. Library, you kind of went to you bypassed the way forward slide, but I'm sort of keen to hear what we're gonna do to fix it, because just what we see in terms of the adult population says to you that some interesting things are taking place at the level of our children and adolescents. And from what you have presented, it would not appear that we're giving it the kind of priority that we need. What is being done or what can be done to have it get the kind of prioritization that it requires?
Okay, well, all right, the way forward that I have here is other areas are, I would say, leaning into the mental health arena, like adolescent health. A lot of that is mental health. And by so doing, mental health is being bolstered. Places like the Teen Hub, where we introduce like mental health referral stuff. The Teen Hub, I don't know how many of you have heard of it. It's like a non-traditional way where place where teenagers can go and do a number of things, including be referred for mental disorder if they wish. But it's not a regular clinic where they're going to encounter the same stigma. So this is one way of I think of what I would say expanding the reach of mental health, expanding the awareness of mental health, expanding the ability to treat. I say more friendly, better equipped sites, less displacement. That is going to be limited. I mean, I'll tell you, one of the doctors, the main doctor said to get a clinic erected now is one of the most difficult things. If we want a clinic, we must get like a container and have it refurbished, right? And which is part of one of the reasons why we're looking at the mobile clinic, because you can have your own little ambience and you travel with it wherever you go. We need more advocacy, higher profile. Dr. Tufton has helped us with this, but it has to continue, more and more and be on a day-to-day basis, year-to-year basis. And the more people we can get involved, the more celebrities and whatever who can speak up, the better for us. Succession planning in terms of like the persons at the ministry, and we mentioned like inpatient care where there's an openness. You're not going to say, oh, all of my people must go to Bellevue. No. Certain persons are admitted at KPH or UE and they are managed there so that there's parity between physical health and mental health. Generally speaking, parenting training, we have parenting support commission. With the violence prevention thing, we are working with them, particularly for the parents of kids who have major behavioral problems. Group therapy activities, well, these tend to go on, like in the clinics. And as you can imagine, it is more economically feasible to do this because you're not dealing with one patient at a time, you're dealing with a group, and sometimes the group dynamics can help. Wraparound services, again, that's like citizen security, CSP, citizen security plan, where we're working with national security, and we're also working with education so that we can reduce the risk for these kids. We're looking at caregivers in state care institutions. They're employing psychologists, and they've asked us for ongoing training in terms of their caregivers. And they're particularly for, let's say, or like disaster and let's say violence. The kind of endpoint is basically sometimes quite a lot of it is trauma. So we are kind of pushing trauma, what we call trauma sensitive care, for people to be aware of it, and for our teachers and healthcare workers. You have psychological first aid, and then you go on to trauma focused, like CBT, if the first aid is not sufficient. Okay, so getting your whole healthcare and social and your whole society. And I mean, people talk about this, everybody says, oh, I'm traumatized. It's like a buzzword now. So getting heightened awareness of this and the fact that people need care and need to be cared for in a certain way. So those are kind of some of the ideas that I've cited here. I don't know if you have any more recommendations, Mrs. Williams, Rena, or anybody else on the call.
Thank you for this, Dr. Leiber. And my own recommendation would be to significantly beef up the communications So we get all the stakeholders really understanding what it is that we're faced with and the absolute necessity of them playing their particular roles, whether on the system side or on the client factor side. So thank you. Thank you again so much.
All right, you're welcome. Okay, any other questions or comments? Normally, I would ask everybody what they're doing and so forth. We didn't have time for that. I presume most of you are in the health sector, so I just wish you all the best with this course and with your career from now on, and just ask you to be an advocate for mental health, especially child and adolescent mental health in the future. Okie dokie.
Thank you.
All right, good. Bye-bye. Take care.
All right, take care, Doc.
All right, bye.
All the best.
Thank you.